Interactive case: the exhausted diaphragm in a pediatric ICU, PICU. Case presentation: you are a medical student on rotation in the Pediatric Intensive Care Unit, PICU. A 6-year-old boy with a history of severe asthma and recurrent respiratory infections is admitted for progressive respiratory distress over the past 48 hours. His parents report that he has been breathing rapidly, looking exhausted, and unable to eat well. On examination: respiratory rate 40 breaths per minute, heart rate 130 BPM, oxygen saturation 89% on 6L-min nasal cannula. Use of accessory muscles: severe intercostal retractions, nasal flaring, breath sounds, decreased air entry bilaterally, scattered wheezing. Paradoxical breathing: abdomen moves inward during inspiration instead of outward. Arterial blood gas, ABG, pH 7.28, PaCO2 60 mmHg, PiO2 58 mmHg, HCO3 26 meqol. A chest X-ray shows hyperinflated lungs and a flattened diaphragm. Question 1. What is the most likely explanation for this child's worsening respiratory distress? A. Pneumonia. B. Respiratory muscle fatigue. C. Bronchiolitis. D. Foreign body aspiration. Answer: B. Respiratory muscle fatigue. The child's rapid breathing, paradoxical movements, hypercapnia, and worsening fatigue strongly suggest his diaphragm is failing to meet the increased work of breathing. Severe asthma, hyperinflation, and prolonged increased respiratory effort have exhausted his diaphragm, making him unable to maintain adequate ventilation. Question 2. What factors contribute to respiratory muscle fatigue in this patient? A. Increased work of breathing due to airway obstruction. B. Diaphragm inefficiency due to lung hyperinflation. C. Malnutrition from decreased oral intake. D. All of the above. Answer: D. All of the above. Airway obstruction from asthma makes the diaphragm work harder. Hyperinflation flattens the diaphragm, reducing its mechanical efficiency. Malnutrition weakens respiratory muscles, making them more prone to fatigue. Together, these factors create a dangerous cycle where the respiratory muscles progressively fail. Question 3. How can we assess whether respiratory muscle fatigue is contributing to respiratory failure? A. Pulmonary function testing. B. Transdiaphragmatic pressure, PDI measurement. C. Bronchoscopy. D. Serum lactate levels. Answer: B. Transdiaphragmatic pressure, PDI measurement. This test measures the strength of the diaphragm and can help determine if diaphragm fatigue is a major contributor to respiratory failure. It is particularly useful in patients with impending respiratory failure and can predict the success of extubation. Question 4. What is the best initial management for this child? A. High-flow nasal cannula at HFNC. B. Immediate intubation and mechanical ventilation. C. Non-invasive ventilation NIV with BiPAP. D. Diaphragm strengthening physical therapy. Answer: non-invasive ventilation NIV with BiPAP. BiPAP helps reduce the work of breathing by providing pressure support, preventing further respiratory muscle fatigue while allowing CO2 clearance. HFNC IEM may not provide enough support for severe fatigue. Intubation, a B, should be reserved for cases of complete failure where BiPAP is insufficient. Diaphragm strengthening is helpful in recovery, but not in an acute crisis. Case outcome: the child is placed on BiPAP, which immediately reduces work of breathing. Bronchodilators and corticosteroids are given to treat asthma. Nutritional support is started to replenish energy stores. Frequent monitoring ensures he is improving without needing intubation. After 48 hours, he is weaned to HFNC and later discharged with a long-term asthma management plan. Key takeaways: respiratory muscle fatigue is a real and life-threatening condition in critically ill children. Severe asthma, hyperinflation, and malnutrition contribute to diaphragm fatigue. Paradoxical breathing is a red flag for impending respiratory failure. BiPAP is often the first-line therapy to offload the diaphragm. Transdiaphragmatic pressure testing can help predict extubation success.